Good morning, everyone. Good morning. Nice to see you all. I've been doing this a couple of years now, but this is the first time I'm doing this one. Normally, I come out and do a presentation called "The Four Things That Matter Most." Anybody seen that in the last year? Yeah, okay. I like that a lot. My name is Doug Schilling. I'm a licensed clinical social worker. I'm the manager of our professional development department. It's just a fancy word for the education department, both internally and externally. And I am about 5 months shy of my 20th anniversary at Community Hospice. So I'm looking forward to that. I have been in the role over the years, both an admission manager, and then for a while I was the manager of our Honoring Choices Advanced Care Planning Department. Then I was a teacher in the education department, and for the last 10 years or so I've been the manager. My background before coming to hospice 20 years ago was mental health. As a therapist and clinical director. So it was a bit of a shift for me. And I think it was sort of a good thing that I started in the admission department, because looking back on it, it means I sort of learned about hospice from the front and back, which makes sense and helped me to know as much as possible. And really that's what I want this to be about. Is an opportunity for you to learn things that you may not have learned as much as you'd like about, to be able to understand and maybe have some strategies about how you can be talking with people about some of their misunderstandings and myths about what hospice is and isn't, because let's face it, and I'm preaching to the choir, you know there are a lot of misunderstandings out there in the world about what hospice is and what it isn't, and how that happens. So I want this to feel like you're getting some ideas about how you can respond to that. And there was a woman in the last group who talked about how somebody started asking her questions and talking with her at Trader Joe's about some stuff. And so we'll call it your Trader Joe's speech. I want to make sure everybody feels like they've got at least a little bit of a Trader Joe's speech that they can use. We in the past might have called it your elevator speech, but we'll call it the Trader Joe's speech as a
I go there twice a week after I do my volunteer work, and I always get comments. I'm wearing my shirt.
Yeah. And I'll bet one of the comments that people are pretty used to getting is, gee, how can you possibly do that? It must be depressing to work at, or to volunteer with people who are dying in hospice. I always have found that interesting in that, for me, this is the only job I've ever had in my life where I look forward to going to work every single night. And if for no other reason, it's because every night when I get home, I know I've made a difference in somebody's life. And that makes it pretty easy to look forward to going back to do it again the next time you've got to go. So the reality is, yes, we do deal with the fact that people are experiencing a loss and people we might get connected to through our work or our volunteering die. And that it can be a difficult thing to deal with. But certainly, for the most part, my experience and what I've been exposed to in terms of our staff and our volunteers is that what you get out of doing this is so much greater than what gets taken out of you because of that other reality. So I hope that's also true for you all. I tend to be sort of casual about how I do my presentations, if anybody's seen me, which at least partly means that at any point here as we're going along, if you've got a question or a comment, raise your hand, let's do it. You don't have to wait until the end. Or if there's, and we'll try to make sure to save some time for questions as well. But let's do it as we're going along rather than some other way. Okay. So one of the most common myths out there, and I experience this all the time during my 7 years in the admission department, I had people say to me, I'm not ready to go to hospice yet. Because the notion is that hospice is a plague. And what happens when you become a hospice patient is we scoop you up and we take you off to this secret, mysterious hospice place and put you in a bed and hold your hand and wait for you to die. And the reality is that nothing could be really farther from the truth. 70% of the American public says they want to die where? We know that. That's been a part of the hospice philosophy and mission from day one. Anybody know, by the way, when the first hospice was opened in the United States? Let's hear some guesses.
1976.
19 what? 76? At first I thought you said 1926.
Is that 70?
70?
In the 70s, so.
Yeah, anybody think it was much earlier than that? We seem to have a group that are rallying around the 1970s. 1974. So yeah, but very close.
I went to the first one here in the United States,
In Connecticut?
in Connecticut, Bradford.
Yeah. Yes. So really, in the big picture, that's not all that long ago. I was a junior in high school in 1974, and so it doesn't seem that long ago to me. And the fact that we've gone from 1 to 6,500 in the United States in that period of time, it really says something when you think about it. I mean, it's not McDonald's growth, but not bad. But on any given day, and today we're taking care of about 1,520 or so, 30 or so patients at community hospital. 92 to 95% of our patients on any given day are getting our care where? In the place they think of as home. Not a hospice place. Do we have inpatient units? Sure. We're going to talk about that a little bit coming down the road. But that's a very small percentage, typically 5 to 7% on any given day of our patients are in any of our inpatient units. Hospice is not a place. Hospice is about a way of providing care for people that we refer to as palliative type care. Palliative care is a segment of the overall healthcare continuum, right? One segment, it's probably the newest segment of that continuum. Palliative care as a healthcare segment is relatively new in the big picture of things, right? Preventative care is probably the front end, where we're trying to keep people from ever getting sick in the first place. Right? And we know that it's not going to work 100% of the time. So what do we need after preventative care? We need a segment that is curative care. Right? So how do we make people better once they do get sick? And that's a pretty big segment, and that segment has been around for a long, long, long time when you think about it, really. And probably we could add at the end of that curative a little segment that we could call rehabilitative healthcare, because sometimes to make you as better as possible, not only do you need a cure, you need a little rehab in between to make you strong enough to be as independent as you really want, right? And then comes the segment that we call palliative care. And palliative care is about a few things. It's about managing symptoms, whether they're physical, emotional, or spiritual. It's about teaching and training the patient about what's happening, what their diseases mean, what's likely to come in the future, what to do about it, and teach and train their caregivers as well. That's a big, important part of what it is we do. You know, we're not there 24/7, but almost always, by the time somebody becomes a hospice patient, there's some group of people or somebody that's there trying to fulfill a commitment to help somebody they love, care about, be able to stay at home and die surrounded by the things and people they know and love. Because we know 70% of the public report on any survey, I want to die at home if I can. And so a big part of our mission is helping those people who have made the commitment to try to make that happen for somebody they care about come true. It's part of why every new employee group that comes through, since I am lucky enough to get to be a part of their orientation, I tell that group, here's what I want you to remember during your entire hospice career. Make the family the heroes. A big part of our mission, and family applies to caregivers who are not family members, but when I say make the family the heroes, what I mean is that group of people that are trying to help this person die a comfortable, respectful, peaceful, positive death in the place they think of as home. So that's what it's about. That's what hospice is about. And the palliative continuum begins to make sense for people, maybe even just a little bit, at the point where they are diagnosed with a chronic illness. Because what does a chronic illness mean? It means we're not going to cure it. And so what are we doing instead? We're managing it, and we're making their life be as good as possible, the notion of quality of life, and teaching and training and helping people to think about and sit down and plan for their future and do their advanced care plans and have conversations with their loved ones and caregivers. That's what the continuum of palliative care does. When we have chronic illnesses, in general, those symptoms are not going to get easier to manage over time. They're going to get harder, more complicated, be more of them. More comorbidities as we get older are likely to come along. Now you've got 3 illnesses you're trying to manage. Not only do you have COPD and some congestive heart failure, your blood pressure needs to be in control. Now you've got 4 doctors who, by the way, aren't talking to each other. And so palliative care begins to make sense, and again, maybe just a little bit, at the point at which somebody is now having to shift gears from curing to managing. And so about 10 years ago, after having done hospice palliative care for 35 years, this organization started a palliative consultation division, which essentially means outpatient palliative care. So if we want the definition and understand the difference between what is palliative care versus hospice, one way to think about it is that all hospice is palliative care, but not all palliative care is hospice. Because for the last 10 or 12 years or so, we've been able to provide palliative consultation to patients, first of all, in a hospital around the area. The only hospital when we started community palliative consultations that had a palliative department was Mayo. None of the others did. And so they wanted us to be able to provide that. If you went to the hospital at Baptist downtown and your attending physician thought, gee, really it would be great if I could get my patient a palliative consultation. Prior to that, it didn't happen. When we started doing it in all the hospitals other than Mayo, we created for our community the opportunity to get palliative input, palliative consultation. Even if it was just an initial consultation with a palliative team of doctor, nurses, social work, chaplain, whenever somebody needed, related to those goals and missions of palliative care, symptom management, case coordination. Somebody that was willing to talk to all 4 of your doctors to help them know what was going on in the big picture. It's part of what palliative care will do. We've taken that on as our role within the overall healthcare community with that kind of an outpatient palliative care approach. And then there's the hospice component of palliative care, which is designed from the get-go, from that very first hospice here in the United States, to be available to people who the medical community thinks may lose their life in the next 6 months. People that are with hospice longer get more out of it than people who are in hospice short. But it's about an approach to healthcare that's related to beyond the curative and preventative continuum, the one that makes sense at that point. Now, does everybody who's facing the reality or the information that that curative care is no longer viable or likely to be, are they embracing the idea of the hospice right off the bat? No. And part of the reason that our outpatient palliative care can be successful on the level it is because some of those folks are going to want to continue with some palliative care, but they're not ready yet for hospice, even though physically they might meet all the criteria. It hasn't gone from here to here yet. Right? And that's okay, that's understandable. We can continue to provide various levels of palliative assistance through our outpatient community palliative consultant. We now do palliative outpatient consultation and intervention in people's homes, in long-term care facilities. And because of that, about a year ago, we broke off our divisions into CPC, Community Palliative Consultants, which happens in the hospital, and then Allevia Supportive Care, which is available as palliative consultation for people in their own homes or in long-term care facilities. So now we can do it pretty much any place anybody is. But hospice is what's designed for palliative approach to people's care for the last 6 months of their life. When you survey the American public about dying, and you ask them questions like, describe a good death, which does sound a little bit like an oxymoron right off the bat, I get that. But here are the things they tend to say. I don't want to be in pain. I don't want to be struggling to breathe. I want to be in control of what happens to me for as long as I reasonably can. I don't want to be a burden on my family. So think about those things for a minute in terms of what is it that hospices do? All of those things are exactly what hospices are designed from the get-go to do. Manage people's symptoms, whether it's breathing or pain, which are the two biggies that people really talk about the most. We want to teach and train the people that are helping to take care of you so that you're as little a burden on them as possible. We're able to say to people, we're going to help you not be a burden, because not only we're going to teach your caregivers what they need to know, we're going to be there to support them around the clock. And if you need a nurse in the middle of the night, we got one that's going to get there. And if you just need to talk to a nurse in the middle of the night so she can tell you what you got to do to make your loved one feel better, we got you there too. And lastly, the notion of I want to be in charge of what happens to me. So one of the reasons why I have been able to say, I think, that this has been the only job I've ever had where I look forward to going to work every day is also because of this. Because I know that one of our missions is to find out what's most important to every one of our patients and caregivers. Now, we use the phrase quality of life, and we tend to throw that around without really getting down into the weeds, but what does that mean? And if I ask somebody in the room to give me the universally applicable definition of quality of life, the reality is it wouldn't be accurate. Because I could go around the room and we'd all agree on a lot of things. But there's also the possibility that every single one of us may come up with something that's our own unique definition of what quality of life means to us. Well, one of the most wonderful things about the palliative care approach and about hospice is we can and should, and our people are trained to find out what that means to every individual patient or caregiver. What is most important to you? And I learned fairly quickly on in the admission department, without knowing a whole lot about what hospice was all about at that time, that I was just as likely when I asked somebody, what's going to be most important in terms of how we can help you, hearing things like somebody say, well, 25 years ago, I had a fight with my brother about the family business. We haven't spoken to each other since, and I don't want to die. Not control my pain, not help me with my breathing, but stuff like that. Which is partly why the whole hospice philosophy is not just about physical symptoms, it's about emotional and psychological stuff. It's about spiritual stuff. And so for that patient, part of that patient's treatment plan, as determined by them, in terms of what was most important and what a quality of life mean to him, was help me see if I can change things a little bit with my work. And so one of the most fabulous things in my view about hospice is, if Mrs. Jones, an 85-year-old hospice patient, says, quality of life for me, even though I'm a diabetic, is to have 2 Krispy Kremes every morning, we're not going to say, oh no, Mrs. Jones, no Krispy Kremes for you, like they have to in the preventative world, and like they have to in the curative world, right? Because Mrs. Jones just defined for us what quality of life means to her. Now, I use that sort of as a metaphor, but it's reality as well. It's a whole different focus and mindset about what it is we're trying to accomplish. It's about trying to guarantee people their dignity and respect for them and allowing them to be in charge of what that last final journey of their life is going to look like. And having all the tools we need to be able to help be a part of making that happen. Even if I don't get those 2 brothers hugging each other in the living room and having dinner together every night, if all I do is open a window as that team social worker where things may change a little bit before that patient died, I've done my mission. I've moved that rock a little bit forward in terms of trying to do something that that person just defined as being quality of life for them. And that's what the palliative continuum is all about. Then the last piece of that continuum is what we provide to the people who are still going to be here after their loved one is gone. The bereavement services that we can provide formally and informally for up to 13 months after somebody has lost a loved one in our service. And so that's the very last component of the palliative continuum. So it might be months or years of palliative involvement, a little bit, and then growing over time. At some point, the medical team may be saying, we think there's a possibility they may lose their life in the next 6 months. And that's when we are going to try to help them to see how they'll benefit from hospice. And then we're going to be there for the people that are still going to be here after that person is gone. And that's our continuum, and that's what hospice and palliative care is all about. And that's how palliative care, it might be different than hospice palliative care. So again, all hospice is palliative, not all palliative is hospice. Yeah, we provide our care no matter where anybody is. And on any given day, like I said, 95% of the time, that's in the place they think of as home. But I did, in fact, admit a couple of patients back in my admission days who were homeless and who said, I'll meet you under the Acosta Bridge at 9:30 every Monday for you to check me out. And so for a while, that's what we did while we were working on trying to find a place that they could live. And so one of the nice things about being a not-for-profit, community-based hospice is that we can make decisions like that because we don't have 5,000 shareholders who are saying, wait a minute, when you provide services for free, it takes off my profit margin. That's not something we got to worry about. And part of the reason why from the get-go we've had a foundation that have helped raise money for us with our community partners so we can do those things we're not having to think about. We can make our decisions based on what we know would be best for our community and based on what we know would be best for our patients. We do have inpatient units where we can, under certain circumstances, take care of our patients. There has to be a definitive reason, and we have to be able to document that we were not able to keep that person comfortable and meet their needs in a less intense environment. We have to do it for a shorter period of time as possible, or else the system can come back and say, okay, community hospice, we want you to give us about $50,000 back because you kept Mr. Jones in the inpatient unit 2 days longer than you needed to. And there are a lot of hospices out there that if you Google them, you find out about all the money they've had to pay back to the system because they were playing games. We have not had to worry about that. Yes, ma'am?
When you say the system, you mean Medicare?
Primarily CMS, but private insurance companies almost all now have benefits for hospice because they tend to follow what CMS does. And the private insurance company can sue you and try to get you to give them back money if you can't show that there was a legitimate reason why you kept somebody in an inpatient unit.
Sir?
Yes.
So who goes to these facilities?
The criteria typically are things like if somebody has an exacerbation of their symptoms, a worsening of a symptom, and we try to get it under control in a less intense environment. Let's say we spend a day really trying with pain medication to get somebody's pain under control, but we can't. That would be a justification, for example, of transferring them temporarily to our inpatient unit where we can have our hands on them 24/7.
Okay.
And where we can be more aggressive with our pain management to get it under control and then get them back to the place they think of as home. If somebody, for example, let's say has family caregivers at home and 5 new medications or equipment needs to be used with their loved one, they're going, oh my God, I'm overwhelmed by it. We could, for example, put somebody in an inpatient unit for a couple of days while we're teaching the caregivers or family members how to do it and getting them a chance to be able to show us that they can. Then we send that person back home. So things like that. It can't be just used as a residential placement. Can't be just used and this happened a lot when I was in admissions, where people would say, well, my grandfather died at the Hadlow Center there on Sunbeam, and it was such a wonderful, peaceful place, and he got such great care. Can my mom just go and live there for the last 2 months of her life? No, unfortunately, we can't do that because if we do, there's certainly a great possibility that we would get in what we call in the industry a heap of trouble. And have to give back a heap of money. Yes, ma'am?
But you do have respite care. I mean, I volunteered
Yeah.
at the hospice, so like a family member wants to go to a wedding and is taking care. You
Yeah.
have like a 3-day respite.
The respite benefit in hospice is actually up to 5 days at a time. And we try whenever possible to use one of the closest long-term care facilities that we have a contract with, because we have contracts with some, to be able to do that, place the person there. Or our inpatient units we can use for respite care. And like I said, up to 5 days. And it can be if the caregivers have become overwhelmed or sick themselves, or they may have a family emergency or something that's taking them out of town. And then that can be the criterion for placing somebody in a respite care placement, again, for up to 5 days at a time, to respond to that. Thank you, good info. Yes,
I have a question about the long-term care. They don't provide palliative care when you're in a long-term care facility? Aren't they taking care of the person? Is it that?
they are taking care of them.
It's not the same thing.
It's not the same thing, and it sort of depends on what your definition of palliative care is.
Okay.
Based on our definition of palliative care as being the experts in palliative care, there are a lot of places that don't do palliative care. There are some places that say they do palliative care that we also feel is not palliative care, despite the fact that they say they do that. But there are some places that do have a different approach for folks who are designated in a palliative care setting, in a long-term care facility, and try their best to do that. For some people in the healthcare world, in that environment, palliative care simply means we're going to take away anything that would be designed to make you better. And that's not all that palliative care is. And so the lack of curative care approaches does not in and of itself designate what we think of as being good, reasonable, appropriate palliative care. And frankly, what we've seen since the pandemic is that many, if not most of the long-term care facilities, understandably, can barely keep their staff filled, much less provide a whole additional, more expensive, more intensive approach to palliative care. So the fact that they can get some of that on a consultative basis from us is something they're really appreciative of, almost always. So we've closed some of our inpatient units. By the way, when I started here 20 years ago, we had 2 inpatient units. The one, the Hadlow Center there on Sunbeam, and the one, the Morris Center in the pavilion at what was Shands Hospital at the time. Now, technically, we have 10, although we've closed a couple of them down. The Acosta Rua Center, we made a huge office complex because we needed it. We have closed down the Hadlow Center temporarily while we're constructing a big pediatric component. So those folks have been moved primarily to the inpatient unit at Ascension, the St. Vincent Southside. And we moved the Morris Center over to the main hospital and made it much smaller, fewer beds, because the hospital said they needed the space back for their own stuff. But we've got very specific criteria for why we can use inpatient units and not. Now, do we admit people who have 6 hours to live? Yes. Do we admit people who have 6 days to live? Yes. We admit people in 6 weeks, of course. But the people who get the most out of hospice are ones who are with us for as long as possible. And 6 months really was designed not as an arbitrary, let's pick a time frame. How about the end of the last 6 months? Yeah, that sounds good. No, really everything we do is geared to be the most successful when we have the opportunity to provide it to our patients and their family for a 6-month period of time, if not longer. Is it nice that we can provide bereavement counseling to people who only were a hospice patient for 6 hours? Absolutely. That's worth the admission right there. The reality, though, is how much it costs us to admit a patient for 6 hours is more than what we get from it. So it's actually a loss to admit patients for 6 hours. Doesn't matter, we're going to do it anyway. We're going to do it if for no other reason, because we know how important and valuable those bereavement services are to be made available for up to 13 months free to the people who are still here when that person is gone. And we're also going to do it because if there's any one little bit that we can make that last 6 hours better, we want to do it. And lots of times we can. Even if it's just with the emotional component of family members pulled in. When I go out and teach doctors about hospice, or nurses, or facilities, what I say to them is you should ask yourself this question about your patient. Would I be surprised if this patient or resident died in the next year? And if your answer is no, I wouldn't be surprised. It's time to at least probably start having some conversation about what hospice is and isn't, which is why I'm there to teach them about it, and about the idea of maybe some palliative consultation, because palliative consultation, CPC and alleviative supportive care, can be a great bridge into hospice care for those folks who may be physically ready, but not emotionally ready to accept it.
Okay, I spent 20 years in cancer centers, and I can tell you the oncologists I knew, telling their patients about palliative care was like admitting that they were failing, and it was the hardest thing. I mean, I was an oncology massage therapist, and my whole thing was palliative care.
Yep.
They hated palliative.
Absolutely.
They just like.
I know, which is a part of why we try to continue to do that education and discussion
You
with
just
them
said that, and I was like,
as much as we can. And I've been doing it in the professional development department for 12 years. And maybe have seen a little bit of movement in the direction of getting sooner referrals, but not a whole lot. And the oncologists tend to be the ones that fight the hardest regarding not wanting to close the door for curative approaches. And I get it, I understand it. But we also want them to understand our world and why the difference we can make when we have 3 months with somebody as opposed to 3 weeks with somebody is huge in terms of what quality of life is. And I gotta tell you, I also had a fair number of people when I was doing admissions who said to me, well, my oncologist said I could have a 3rd round of chemo, but I don't want to do that anymore. I'm miserable, I'm sick, I've got no life, I can't do anything when I'm in chemo, and I would rather, at this point, given all that we've tried, and where we're at now, be able to live my life as fully as I can for whatever amount of time I have, and there are people who make that decision despite the fact that people, the oncologists or medical team are saying, well, we could do another round, we may extend your life another few months by doing that. The good news is, in this country, we get to be the ones to decide. And anybody who has capacity to make their own medical decisions gets to be the one. And in fact, as part of the survey that people say, I want to be in charge of what happens. I wanna have it available to me to say, I don't wanna do that, I wanna do this instead. And then we do. But I will tell you another little factoid about hospice that is completely opposite to one of the most common myths out there in the world regarding hospice. And that's that if you become a hospice patient, you're gonna die soon. In fact, I admitted about a half a dozen patients during my admission 7 years. So not a whole lot, given that there were probably 35,000 admissions during those 7 years. Who, after I admitted them and they signed the papers and everything was done, said to me, so when do you give me the pill that I go to sleep and never wake up? And they were serious, right? That notion that the hospice kills people, whether it's not because they wanted to, but just because what they do kills people, or because that's a part of what hospice is about. We're going to help you end your life. Number of studies have been done over the years, and this is a great thing to keep in your Trader Joe's speech. Every one of those studies showed that if you've got two patients for whom there really is no more viable curative treatment, with the same diagnosis, and one has hospice and one doesn't, the one with hospice lives longer than the one without hospice. If you collapse all diagnoses, it's 1 month longer on average than the non-hospice patient, and some diagnoses, it's up to 2 months longer than non-hospice patients. So again, two patients for whom really curative treatment is no longer viable or appropriate. With the same diagnosis, one becomes a hospice patient, one doesn't. Hospice patient lives longer in every diagnostic category, an average of 1 month. Some diagnoses up to 2 months longer. So one of the biggest myths out there in terms of what people think hospice is all about is completely false, based on numerous studies. The other thing is, when it came to people who were hoping or wanting or thinking that killing themselves was going to be the best solution, I will tell you this. That all those times where I encountered that, and based on the fact that I was a mental health person before I started doing this, I had a lot of discussions with people about that at the point of admission. And so typically what I would say to people is this: you can always have plan B in your back pocket. Give us a week, just to see if the reasons why you decided that would be the best thing may not be true. And I never once had anybody that I had that conversation with who I said, look, you've always got plan B, keep it in your pocket, hold on to it, because you can always do that. But give us a week. Never once found out about anybody that after a week didn't find that because of what hospice does for every single patient, the reason they thought that was going to be the best plan no longer applied. Yes.
Yeah, and to take that further, I don't remember which Scandinavian country it is, but or European country, but they have physician-assisted suicide, and in one of these countries, the way that they do it is they inform the patient, inform consent, like, here's how the process is, this is how it works, this is what you're likely to feel, and they will present the whatever the chemical is to them, and they said you can do it yourself. You just here's how you plug it into your IV, and they set it right next to their bedside. And they say the decision is yours, and most of the time they don't go through with it because they just want the comfort of I have it there if I need it.
He's right. That's right. That's absolutely right. They just want plan B there, but they don't necessarily use it.
And almost always the reasons behind plan B, having the fact that they came to the conclusion about plan B, are things that we're designed to do something about. So whether it's pain that's out of control and nothing's been able to take my pain away, they almost always find that within a few days, we're able to get it to a manageable level where they don't think that's the best reason anymore. Or if it's some other emotional component, like relationship problems or things that, somebody that they're caring for, that they're worried about what's gonna happen to them when they're gone. They see that we can be a part of trying to make sure they don't have to have those worries, and that their pain can be managed, or whatever their reasons are. Or if it's a sense of feeling spiritually disconnected in a way that they can't tolerate at that point, by working with their chaplain, they feel more connected, or they get a chance to resolve those things. So the reality is almost always the very reasons, the 4 or 5 reasons why people tend to end up being there in the first place are the things that hospices help people with, and so Plan B no longer seems to be the best solution. Obviously, we want to have an approach where what's most important to the patient, what does quality of life mean to them, becomes what we're doing to help them, giving them the opportunity to be in charge of what their life is going to be, helping them to trust the fact that we're going to give them as much quality of life for as long as possible as we can. Well, here's the other interesting thing. And when you're an admission person, it's not unusual to encounter family members who are running interference for the patient. That's putting it nicely. So lots of times when I was at a hospital to see a new patient, as I would be approaching the hospital room, there'd be somebody standing outside the door, right? And frequently they were sort of looking like that. And when I got close enough for them to talk to me, they sort of, metaphorically speaking, would grab a hold of me like a pit bull on the arm, and I started calling them the family pit bulls, and usually say something like, "Oh no, you're not going to go in and talk with Mom about hospice because she'll give up hope and die soon." Now, half the time or so, those folks who were the pit bull outside the door, on my arm and not letting me go, were just grieving family members who weren't ready for their loved one to die. And about half the time, they were control freaks who wanted to be in charge of everything that goes on with somebody they care about and love, and didn't want anybody else interfering or causing problems for their loved ones. Well, when I started this job and started doing this, I figured the best way was to just educate them about how if the patient has capacity to be their own decision maker, by law, I have to talk with them and get them to give me informed consent that that's what they want to do. And then after I got called by my supervisor a couple of times where they said the case manager, a head of case manager at Baptist South said you were rude to a family member, I'm thinking I could not have been more professional and kind and educate them when I said I'm going to have to talk to you, Mom. I started figuring out that I better spend a little time with the pit bull, figuring out whether they were a control freak or whether they were a grieving, upset family member, and devise my strategy based on that. Because if it's a control freak, what am I going to do instead of saying, "Oh, you probably just don't understand the law, let me explain it to you," and think they were going to go, "Oh, now that I have explained it, come on in. Go ahead and see my mom." Because that was never going to happen. So if they're a control freak, what I started doing instead was saying, "You know what, nobody knows your mom better than you. Could you be in the room with us when we're talking so you can help me to know as much as I need to know? And if I need a translator, you'd be it. And so you can have input and know exactly what's being said to your mom, blah, blah, blah." So if I invited the control freak into the process and helped them see, they didn't have to worry that we were going to come in and take charge and run everything. That almost always got them to feel, okay, at the very least, I'll let you have the talk, and I'll be a part of it. And if they were grieving, upset, I'm not ready to lose my mom patient, I would have a different way of handling it. but it still became part of understanding the effect that the H word has on people, and trying to tailor things in that kind of way. I've never found or been told of or made aware of a patient in my 20 years who, as a result of becoming a hospice patient, gave up hope in the way that family members frequently think is going to happen the minute mom sees you're back, or the minute the dad knows he's becoming a hospice patient. It almost seems to me like it's a part of human nature that we hold on to hope even when we may have accepted the reality, intellectually speaking, that we've got an illness or illnesses that's going to take our life at some point. People still seem to hold on to some component of the notion that you never know, maybe something will turn out different. And when you can help people to see, which is a part of what you guys do, that making every day be as important and special and meeting what quality of life means to them, and focus on that, they stop worrying quite as much about how much time they've got left and start looking at how do I make this day as good as possible, and how do I make tomorrow as good as possible, and stop worrying about the long-term future quite as much as they might otherwise. But I've never, and I've dealt with a lot of patients and families. Families are more likely to give up hope than patients. Obviously, we have every single diagnosis that can be an end-of-life diagnosis for patients that are currently our patients. It's not just about cancer. Is the biggest single diagnostic group cancer? Yes. That's roughly 30% of our patient load on any day as a primary hospice diagnosis of cancer. But